Good morning, everyone. My name is Jane Matson. I am the Director of Continuing Education at the Michener Institute of Education at UHM. And this morning, I have the privilege of introducing our keynote speaker for Convergence 2023. Stella Ng is the Director and Scientist from the University of Toronto's Centre for Advancing Collaborative Healthcare and Education, known as CASH, at the University Health Network. Stella has actively worked to advance critical reflection and transformative education toward more collaborative, compassionate, and ethical healthcare and health science. Her Tri-Council Ministry and Foundation-funded research program has shown that critical reflection is crucial to compassionately, collaboratively, and ethically navigating value, conflicted, and uncertain aspects of our everyday work. Her passion was sparked by challenges she experienced as a pediatric audiologist in the public school system, which motivated her to launch her research program in reflective practice, critical reflection, and critical pedagogies. Stella's full bio can be found in our program for Convergence 2023. The title of Stella's address today is Perspective, Growth, and Change, Renewing the Purposes and Promises of Reflection in Health Professions Education. Just to give you a little bit of an understanding of what will happen, Stella will speak for approximately 45 minutes, after which time we'll have plenty of time for questions. We will use the Q&A panel. You'll see it on your screen to submit questions, and I will help to moderate and bring them forward to Stella. I hope you all enjoy her talk. I know you will. It will be interesting, it will be enlightening, and it will be engaging. Please hold your questions till the end and we'll get through to them. But right now, I think we are at the point where we can introduce Stella. She can turn on her she can turn on her microphone and her camera, and I will turn mine off and we can begin our morning session. Thank you.
Thank you so much. Thank you to the entire Convergence Committee and to everyone for joining us this morning. So I am going to dive in with some stories, and I'll be telling a few stories today. One will be about a child or a patient named Jack. One will be about a clinician, and one will be about a clinical educator. And I'm telling those three stories because of what Jennifer just shared with us. Convergence is a place to merge our thinking, our practices, our hopes for research, education, and practice. So the first story. Imagine that you are a clinician. Maybe you're an OT, a pediatrician, maybe you're a family physician, and you are seeing a child and his family, his mother. The child's name is Jack. Jack has been diagnosed with a number of conditions, including ADHD, anxiety, and urinary incontinence. Jack is only 8 years old. Jack's school is really concerned about his behavior. His parents are struggling to navigate multiple systems and to work with different kinds of professionals, getting reports and recommendations from health professionals in clinical settings and shuttling these off to school settings where there are recommendations to help Jack be able to participate fully at school. This is a really common issue, and it leads to a lot of frustration. So you, as that clinician, the OT, the pediatrician, the family physician, you send off a report, and it's full of these strong recommendations to help Jack out. But the school can't implement the recommendations. They say, oh, we don't have the funding for that. That doesn't work in this classroom setting. And Jack's parents become really frustrated while Jack's needs remain unmet. So you're the clinician here. This is a story about something that Jack needs. Your job isn't to diagnose here. It's not even really to treat. It's actually to help the family navigate this really complex web to try to get what is needed. And it might even be unclear, uncertain what is really needed because there are so many perspectives to take into account. So what is this? Why am I telling this story? I often start with this story because it comes from that past practice experience that Jane explained is my sort of starting point, the spark for me to come to this field of health professions education. This that I've just described is one example of many of an indeterminate zone of practice. And an indeterminate zone of practice kind of makes up the majority of all of our work. It means an uncertain or unique or unstable or value conflicted aspect of practice. So where it's not necessarily clear-cut solutions to be applied. It's not necessarily a straightforward diagnosis and treatment plan. I worked at this interface and I saw assumptions get made. I saw practices become entrenched and I saw conflict ensue repeatedly, cyclically. Eventually, I found ways to help things go smoothly. So as an early, just out of school practitioner, I didn't want to see parents be upset. I didn't want to have grandparents calling me at night crying because their grandchildren couldn't get what they needed. So eventually I found ways to help things go smoothly. I listened, I validated, people would feel heard. Maybe they wouldn't cry or maybe they would stop crying by the end of the conversation. And hold on to that because I think at that early stage in my career, I thought that I had worked something out, and I think I had. I had helped people feel heard, and I was working within the system to try to make things work as much as I could within the current confines of the system. So you could argue I was engaging in reflective practice. So reflective practice is based on a number of different theories. It's sort of an umbrella term at this point. And I like to focus it on a particular aspect, which we'll zoom in on right now. So not so much self-reflection, more so reflection about knowledge. So John Dewey defined reflection as active, persistent, careful consideration of any belief or supposed form of knowledge in light of the grounds that support it and further conclusions to which it tends. So we often think of reflection as thinking about ourselves and our emotions, and not that that's not reflection. It's just not the focus today. It's really about questioning forms of knowledge and what those forms of knowledge lead to. So when this is applied to practice, it can be called reflective practice, and you can engage in that type of reflective thinking before practice. So maybe before your presentations today, if you're presenting later on, you're maybe planning ahead how things might go, thinking about who the audience is and how you might engage meaningfully. You'll reflect in action. So as it's going on, I can't see faces, unfortunately. You'll be able to see faces and you can respond in the moment and adjust what you're doing, demonstrating that knowing in action and reflecting in action. And then you'll probably reflect on action. This is where we tend to focus a lot of health professions education, where you'll look back, maybe you'll debrief with someone, maybe you'll write something down to think about what could have gone differently. While we focus more in health professions on the reflection on action, it's really not the crux of reflective practice. Reflective practice is more about the reflection in action, which is a way of seeing and being and doing. So think of it as how knowledge is created and enacted in those indeterminate zones of practice, how you navigate through those sticky situations. When you add critical in front of reflection, so I said I'm not focusing today on self-reflection, I am focusing on critical reflection. When you add critical in front of reflection, it means that your lens includes questioning of assumptions, your own assumptions about others and how the world works, societal assumptions about what it means to be disabled or to be a healthcare professional, power relations, so the differences in hierarchy and opportunity between different professions, between different groups of people, and examining how these assumptions and relations shape practice. And when your assumptions or when power relations might be harmful or problematic, a critically reflective practitioner is compelled to make change the situation. So when you think of my example with Jack, I found a way to smooth things over. I found a way to have people not be as upset. I didn't necessarily change the system. So I was maybe doing micro level change to help work around a broken system. I wasn't changing the larger system because it's a long road to change. I don't know how critically reflective I was being at the time. I think I was being reflective. It is a really long road to change, although you can make micro moments of change happen every single day. And one of the first steps on that road is to change your perspective or grow your perspective. And this brings me to my second story. This is about a clinician, and this story comes from the work of two of our local colleagues, Drs. Paula Rowland and Ayelet Cooper. Paula is doing a podcast at the end of the conference. I would encourage you to check it out because she's always brilliant and fascinating. So this comes from a study that Paula and Ayelet conducted, where they were talking to clinicians who had a dual role because they became patients. The following participant is a young, otherwise healthy woman. She had experienced a rare infection that resulted in hospitalization and subsequent isolation in general medical unit. Her own clinical work had been within a general medicine unit at another hospital. As such, the routines, practices, and rhythms of the unit were well familiar to her. In recounting one particular day, she focused on the food tray that had been delivered outside of her door. Having already decided that the hospital food was unpalatable, she had her own food with her in her room. But after a few hours, she realized that her breakfast tray was still outside the door. No one had delivered it, and no one had checked to see if she was hungry. As the day went on, she continued to notice that tray, still waiting. As the afternoon turned to evening, the tray began to represent the loneliness, the isolation, the feeling of stigma that pervaded her experience as an inpatient. A particularly profound moment in this interview was when she said, "And I thought about how many times I would walk by patients who were in isolation, and I would see their trays, and I would just say, it's the nurse's job to bring that tray in. And I said to my husband, I said, and she became tearful, if I ever go back to medicine and work, I won't walk by those trays." So that comes from Rowland and Cooper 2017 in their paper, Beyond Vulnerability. This clinician and others in that study gained perspective. Unfortunately, they gained it in a way that we would not want to use pedagogically, although we would invite it pedagogically. So it's important to say we want to invite in education people's learning from all aspects of life, not just formal education, because our learning from all aspects of life can improve how we practice. Rowland and Cooper and others, including Eric Mikulovsky, some of my own colleagues and collaborators, have shown that often that perspective shift, that critical reflection that can lead to more compassion or more collaboration, or better compassion, better collaboration, it's often learned by happenstance. Maybe you become ill, as in this study. Maybe you know someone, so there's a relationship that lets you see in another way. And surely we don't want that to be the pedagogy, go learn by accident. So Rowland and Cooper concluded, and they cited me, so thank you, Paula and Ayelet, that the development of the ability to critically reflect need not wait for the happenstance of painful personal experience, but could thereby be fostered through both curricular content and pedagogical techniques. And so that's what I'm going to share next, a study that examined some pedagogical techniques to see if we could get at that same sort of perspective shift without someone having to go through something horrible, or without someone having to have connections and networks that enabled them to shift and gain their perspective. So in this study, we tested two different ways of teaching. I have to give a bit of background in order to explain. You'll notice a lot of the authors on this work are local and some of them are presenting. I don't want to miss anyone, but I'm pretty sure Adam Gavarkov's and who else? Victoria Boyd, they are both presenting at this conference. So what we were testing out was an approach to critical pedagogy based in the work of many scholars, including Bell Hooks, Paulo Freire, Joe Kinchelow. There are ways to teach for critical reflection. Perhaps they haven't been explored empirically very often, yet they have been shown experientially, qualitatively. A prerequisite for critical pedagogy, especially in our healthcare contexts, is to acknowledge and foster an appreciation for those kinds of knowledge that I just talked about. So learning from personal experience should be welcome. And in order to have that be welcome, we need to think about this hefty word, epistemology. So interestingly, reflective practice has been termed an epistemology of practice, this understanding of how knowledge is created and shared and mobilized and adapted in and through practice, so that knowledge is in your doing. You can keep growing your knowledge through your doing. It doesn't mean you're not adopting textbook knowledge or scientific knowledge, yet you're also incorporating personal experience, practical experience, patient and client knowledge. And an epistemology of practice acknowledges those indeterminate zones of practice as common. And it's how you navigate those messy moments of practice that really makes you a practitioner. So not someone who only applies protocols and rules in straightforward situations, someone who can also navigate the messes through building upon your past knowledge and creating new solutions. A second component of critical reflection and that grounds critical pedagogy is this notion of critical social inquiry. So this constant questioning and challenging of assumptions, disrupting what is dominant, and trying to make the system better, more just. So when we're talking about teaching for critical reflection through critical pedagogy in the health professions, a number of scholars in our local community in higher education, Megan Bowler, and in our health professions, Arno Kumagai, have adopted this work into these contexts. And I'm going to share two examples quickly here so we know what we're talking about. The first, and this is my third story about a clinical educator, is for you to imagine that you are a clinical educator and you're working with a learner. I'll be more specific here. Imagine that you are an audiologist and a clinical educator. The learner who is working with you today happens to have a visit from a client who is a member of the deaf community, somebody who is a part of deaf culture, capital D, deaf culture. This patient or client is here for a routine visit. He uses a hearing aid for awareness only, not for speech recognition, just for awareness of environmental sounds. And your learner, who's, fresh out of best practices, evidence-based practices in school, says to the patient with good intentions, "Have you ever considered cochlear implants?" The patient or client is very upset. And keep in mind, this is happening in a climate where public trust in healthcare is already a concern. So you are the clinical teacher, and please use the chat. I checked that the chat is active and I think I should be able to see it. And just take a moment and think about what you would do. So you see that your student has just asked a member of the deaf community if they have considered cochlear implants, and that patient is very upset. You have a dual responsibility here to the patient and to the student. What might you do? And please just type into the chat anything that pops into your head. Multiple possible answers here. It's not like we're looking for one right answer. What might you say to the student? Who would you sort of support first? Would it be both the student and the patient? I will wait very patiently. Okay, Jennifer, I might need you to help me out.
I was just thinking that's such a great question. And I'm just like, who do I go to first? And I'm trying to struggle to write, like, do I support the patient first and maybe take the student aside? Do I use it as a learning opportunity? My brain is sort of exploding as to who do you go to someone? Like, how does that sort of work? And so, yeah, that's why I was like, I'm typing and then I'm erasing and then I'm typing again. So I think that's a conundrum right there. Oh, here we go. Maria.
Thank you, Maria, Farine, Nancy. Seems like everyone's going to support the patient. So how would you support the student? I know this is hard to type into a chat. This is one of the challenges of webinar style. How would you support the student? So ask a question to facilitate learning. Ask the student, how might the client feel about that comment? Thank you, Jess. So we're talking about perspective, growth, and change today. So Jess's question is asking the student to consider the client's perspective in that moment. So this is an example of an opportunity for critical pedagogy in the moment, in the moments of clinical practice. A lot of what you might read on critical pedagogy is described in classroom contexts. Sometimes these moments happen in real time and you don't have a lot of time to debrief. Yet asking questions like what Jess has just posed here can be a way towards critical pedagogy, where first, as others have noted, you're going to support the patient, make sure that they're okay, maybe try to repair some of the broken trust that has just been caused by an innocent mistake. And then you're going to ask questions of the learner that maybe help them adopt different perspectives. And this is tricky because the entire profession, the main purpose of the profession is to help people hear. Yet this is an example of when that dominant way of thinking goes against a person's needs and goes against a particular culture. And it can become rather sensitive if one is not more critically aware. So that example actually comes from my own experience, except that I was not the clinical educator. I was not a student. I was a practitioner. I was working in a private practice and I asked that question. And I'm sharing this because I think it shows that need for growth. And we'll get to the growth piece in a moment. I wanted to also share some approaches for doing critical pedagogy in the classroom. So I won't go through this because I think it is a little bit more challenging in a webinar format. But what we did in the study that I'm about to explain is we shared this image with a small interprofessional group of learners seated in a circle in a really sort of small room. The atmosphere is part of the critical pedagogy. And we asked questions of this image, like what stands out for you? What language, concepts, or ideas about disability, illness, or care are reinforced or promoted? So for example, triumph over disability, assistive devices in a garbage pile. What kinds of ideas are promoted and perpetuated through this image? And students kind of start to get at ableism, the fact that not everyone can get to the top of that heap. Those who are disabled, if you have cerebral palsy and you're a child and you walk into Sick Kids and see this advertisement, it could be actually harmful. So who do these concepts of triumph over adversity harm, and who do they help? There's obviously a lot of good done by campaigns like this, which raised a lot of money to do good work. What roles are created by these ideas? So who's shown as the problem, or what's shown as the problem, and what and who is shown as the solution, and what possibilities for each role are created or limited. And then always ending with something generative, which is something I've learned from folks who are here, like Maria Tassoni. How else could these concepts be thought about? So how could we recreate these ideas and images to be more helpful and less harmful? These questions I've just shared are not made up. They come from theory, they come from critical theory, and you can look them up in Stephanie Nixon's work and the work of others. So we engaged in this type of learning. You can imagine it's better when it's a small interactive group. We compared these types of critical pedagogy to just standard, still good quality, reflective discussion on social determinants of health. Not critically reflective, but reflective discussion. So we compared reflective discussion to critically reflective dialogue with 16 interprofessional groups of 5 from a number of different professions. Everybody got the same initial starting point, so the same base knowledge, and the control groups got the social determinants reflective discussion, followed by an interactive curriculum and group debrief, and the intervention group received critically reflective dialogue for their educational intervention, followed by the same curriculum and group debrief. So we wanted to see if in this curriculum and group debrief, if the ways that learners talked represented a shift in perspective from their preceding teaching. So if they got reflective discussion versus critically reflective dialogue, did they see their further encounters differently as evidenced by how they talked? So we recorded their talk and we qualitatively coded. And following the qualitative coding, we conducted some Bayesian regression analyses. And what we found was that when groups of learners from multiple professions came together and learned through critical pedagogy, they were more likely to speak in critically reflective ways in a future learning activity when compared to more traditional reflective discussion. Importantly, what they talked about stayed the same. The topics were the same. It was the how that was different. So less likely to be ableist, ageist, more likely to be compassionate, collaborative. So this study showed us how to potentially get to that critically reflective capability that I talked about with the Rowland and Cooper study without the happenstance of having to become ill, or without the privilege of having networks that enabled you to see in another way. So that's a pedagogical example. This conference is about education. And I think a lot of us probably already knew this and had experienced this in a sort of gut or anecdotal or experiential way. And this study provides us with a certain form of evidence that can be compelling in different circles. So all of this is a continual process, and it is not just for students, it's for us. So I keep sharing examples of how I've messed up to demonstrate that it's continual growth. The findings that I just shared shouldn't be surprising because a lot of psychological literature shows that imagining the perspective of another, for example, an out group, can be a helpful way for us to counter stereotypes. So Jessica suggested we ask that learner who harmed or hurt, maybe not harmed, but at least hurt that patient, to consider how the client might feel. And psychological literature supports this approach. This can be a helpful way to counter stereotypes. At the same time, we want to be mindful that none of us can fully and accurately imagine the plight of another. So there are limits to this. How do we then, as educators, keep growing our teaching practices? We can learn from that moment ourselves. So if you were the clinical educator in that story about the deaf patient, you would also learn. It's not just about your learner learning. And we can be deliberate about it to become critically reflective educators. So Stephen Brookfield has suggested 4 lenses to become and remain critically reflective educators. So everyone here I know is here because we're interested in health professions education, and these are 4 lenses we can purposefully consider to become better and better educators. So the autobiographical, that is that self-reflection piece, which I'm not talking about much today. Students' views, which can come from a multitude of sources, course evaluations, especially often the written comments, conversations, invited feedback. So often with our learners, we can go outside of the formal evaluation process and just invite feedback. meaningfully and genuinely invite it and listen to it. I'll stop there or pause there to say, often I'm confronted with a bit of pushback that says students aren't ready for this. They want the recipes, they want the checklists, they want the protocols. And I disagree. Some learners, sure. Recently, I've been more and more pushed and challenged by students. So I might do this type of education, and I have students push that critical questioning even further and give me feedback that can improve my teaching practice. For example, I recently taught in a large course, 70 students. I was trying to sort of work with critical pedagogy, though it's tricky in a large class in our sort of typical structures of the university. And the students said, we like that. Some of the students liked this approach of sort of disrupting the norms of education, and pushed me even further to say, when we share relevant stories that help one another learn, we need more space and opportunities. So it's not like we drop this thing in and then everyone just listens and moves on. And I've been sitting with that since the first week of January to think about how I can improve my own teaching practice. I do think, though, you have to carefully construct the environment where students will give you that feedback. That happened in real time. Colleagues' experiences, another important lens for us to become critically reflective educators and remain critically reflective educators. So all of us here, we're here to learn from one another. Colleagues' experiences can come from communities of practice, conferences, water cooler chat, deliberate meetings. And then finally, and this is sort of the focus of my presentation this morning, theory from the education sciences. So we can continually adopt new knowledge and test new knowledge and merge science and practice to improve how we educate. I love the following quote from a critical pedagogue, Joe Kinchelow. So often people think of critical pedagogy as sort of soapboxes or really extreme activism, and maybe it's focused on social justice. Joe Kinchelow, who is a great leader in critical pedagogy, calls for drawing upon theory from education sciences. So he said, we cannot simply attempt to cultivate the intellect without changing the unjust social context in which such minds operate. So he is calling for justice. Yet critical educators cannot just work to change the social order without helping to educate a knowledgeable and skillful group of students. Creating a just, progressive, creative, and democratic society demands both dimensions of this pedagogical process. So some research shared today suggests that critical pedagogy and dialogue may support education that attends to relationship structures and issues of power. Our experimental studies brought learners from different health professions to learn through dialogue, and it seemed to help us realize desirable learning goals. Key to all of that, though, was clear definitions of all the constructs in question, education approaches that align with those definitions and their paradigms and philosophies, and partnering practitioners, community perspectives, and educators with education scientists to be able to refine and advance teaching approaches. So finally, I'm going to start to move towards change. If we view education as a sociocultural and transformative process, as much as we view it as a cognitive process, we can start to shift towards perspective sharing, not just perspective change, bridging from individual learning toward the growth of the entire learning community, toward change. And what are we trying to change? Change practice and change the system. So Inglis explains that the difference between empowerment and emancipation can be situated in their larger function within a societal structure of power. So empowerment includes people developing capacities to act successfully within the existing system and structures of power. Whereas emancipation concerns critically analyzing, resisting, and challenging structures of power. I credit my colleague Amelia Kangasjarvi with sharing this amazing distinction with me. So remember Jack, the first story that I shared? I noted that I had found ways to help parents feel heard, to validate, to help things go more smoothly, to have fewer tears, to be maybe more emotionally supportive. We got through things. So I found that instead of conflict, we often had conversations and we got through things together. Yet it never really fully sat well with me because it was still certain parents who were able to do the things that they were doing. And ultimately, we were still reinforcing the system because we were creating workarounds within the system. And there were kids who weren't getting anything, any attention, because they didn't have the parents who had the privilege to be able to take the time off work and navigate the system. So I eventually, in that context, had become empowered to work within it. I don't think that other practitioners and the parents and the children were emancipated. Something still felt wrong. Not for everyone, but for some. And that's the crux of justice. It was okay for many. It was working fine for many. And yet it was leaving many behind. So I'm going to pause there. We'll hold on to that difference between empowerment and emancipation, and think about this change piece and how critical reflection can help us get to change. So in another study, a qualitative study, we looked at what critically reflective practice looked like in the real world. So this is right in the context of Jack. As part of a larger institutional ethnography study that included observations and document collection across 4 school boards and a large number of hospitals and rehab centers, we interviewed 42 individuals, healthcare providers, school-based professionals, and parents of children with chronic conditions or disabilities. We wanted to ask, what does critically reflective practice actually look like in this real-world context? And we found, I won't tell you all the findings in depth, just to highlight. There was this recurrent story of a clinician who we'll call for today Dr. Lucy. And everyone across these multiple school boards and jurisdictions and health systems would refer to this as sort of someone who gets it, someone who's figured it out, someone who's able to navigate this complex situation. And when we looked deeply at clinicians like Dr. Lucy, we found that they were able to get to know the other rather than assume. And it didn't always take a lot of time. It was just sort of not assuming that if a school said, no, we can't do that, we don't have the funding, no, we can't do that, it doesn't work in the classroom, that there could be reasons, there could be perspectives worth taking. And it wasn't just about advocating at or against. And we found that this came from valuing different forms and sources of knowledge. So that's the epistemology of practice piece, not only valuing and privileging the clinical knowledge or the evidence base behind a clinical profession, also valuing personal, practical, experiential knowledge. Not to say that those two forms of knowledge are always equal in every situation, yet there's a time and a place for different types of knowledge. And this enabled that approach to advocating with rather than at. We're all in this together. How do we get through it? How do we make change? Rather than trying to sort of take down another in order to get what a child needed. We found that clinicians like Dr. Lucy were critically reflecting, and they were creating workarounds, which may be still within the system, yet they were communicating about the workarounds. So they would say, for example, to a parent, I know that you don't want this diagnosis for your child because that comes with all kinds of things, assumptions, potential perceptions that might not be helpful. Yet this diagnosis also enables access to resources and supports. So we'll take that diagnosis off the shelf and apply it to get what is helpful and put it back on the shelf as much as we can so that it doesn't impede other things. And we had our parent participant say that that communication of the workaround, the why behind the workaround, the acknowledgement that the system is imperfect was so meaningful. And then finally, the seeing inequities. We had participants who noted that this system is skewed. It helps some and it doesn't help others. That may or may not be change yet. It's change in perspective. Is it change in practice? Where we saw change in practice was in material form, in reports and letters. So Dr. Lucy wrote her letters differently. She wrote to the schools, this child needs these things, yes, but also wrote in a more inviting and collaborative way. So these reports and letters became a material demonstration of critically reflective practice leading to change. And that's something that we're continuing to study. And a number of people who are here, Victoria, Amanda, Jacqueline, have been doing this work, not just in research, they've been enacting it in everyday education and clinical practice efforts. And I think many of them are presenting, so check the program out. So winding down now, I wanted to sort of really drive home this imperative for change. Do we really need change? Change for what? Change for whom? And I would argue it's change for all of us, even when it might seem like change for some, because we are all in this system together. So it's still February, right? It's February, it's Black History Month. Study after study shows that our health system is inequitable. Different outcomes for different people. I've been doing a bit of reading lately because an amazing graduate student is studying something that piqued my interest and came across a study. You know, we hear about disproportionate poor treatment of Black patients. And this sentence and this study really struck me. It was a study about restraint in pediatric contexts. And this study, and I had a data scientist check it out and be like, are the stats good? Is this a good study? It concluded that even after adjusting for socio-demographic and clinical characteristics, Black children are more likely to be physically restrained in the emergency department compared with white children. These are children more likely to be physically restrained with other factors controlled for, more likely to be physically restrained because they are Black. This is inequitable, and this requires change. And this change needs all of us and will benefit all of us. So a little less disturbing, but still kind of on the same point. In December, and this story is shared with permission and actually by request from my father, who wants to help change the system. So in December, my own father, who is an East Asian man in his mid-70s, with one cancer diagnosed and another under investigation, he was denied care and left unable to access care within his entire region, the entire region of Halton. It happened at a clinic where he was perceived as, quote, rude. A very silly misunderstanding had transpired when he tried to attend a clinical appointment that he'd been waiting months for. And he tried to clarify the misunderstanding. And he's a respectful man, soft-spoken, with an accent. He's worked as a professional engineer in Canada for his entire career. And despite his complete capability, he can speak English very clearly. He's knowledgeable, he's respectful. He was perceived as rude. And I regret that I didn't accompany him to this one appointment. I've been trying to accompany him as much as I can. And I don't blame any one person, but the fact is he's now banned from a clinic and can't access care in an entire region. I'm sure the clinic was busy, the staff were overwhelmed, my dad was misunderstood, and I believe that it is our systems that led to this injustice, multiple systems, not just the health system, social systems, systems of how we see and perceive and work with one another and relate to one another. And it has led to care denied in our Canadian healthcare system. So do I think we need change? Absolutely. Do I think it'll be easy? Not at all. And do I think we have some ways forward? Yes, and I think that this conference will show that. We need to keep working on education that engenders compassion through the ability to consider multiple perspectives. We need to keep working on ourselves as educators and keep growing. And we need to work together towards change. I think that we need critical reflection for all of this, because the whole point of critical reflection is not only to ask questions and seek change within the current system, becoming more empowered, it's also to question and challenge the system itself, thus redesigning the box within which we work so that change can happen for all of us. So perspective change for learners, by teaching through critical reflection, growth for us as educators by adopting those multiple lenses to become critically reflective educators, and change as a system together, keeping up our criticality. Systems change so that we are emancipated, not just empowered. Thank you so much. I'm really looking forward to a bit of Q&A and questions, and I don't think we can quite get to dialogue in this format, but at least some discussion. And just huge thanks to all the co-authors and inspirers that you saw cited, the Praxis Lab, many of whom are here presenting at this conference, Cash, the most amazing group of critical companions who question and challenge and push me every day, and all of these other institutions, funders, collaborators, and all of you. Thank you so much. I'm going to stop sharing screen so I can see at least a list of people who are here. And I invite any questions, comments, points of agreement or disagreement.
Thank you very much, Stella. That was an amazing talk, and just so much to absorb from your stories that you shared. It's really making me stop and think about education and what we need to do. And as you said, it is now open for the Q&A. So if everyone looks at the bottom of their screen, there is the Q&A sort of tab button. You can add your questions or comments here. And obviously the chat is still working, so I'll try to keep an eye on both. If you'd like to post your questions, I can bring them forward to Stella for her input. And we'll just give it a few minutes so that people can get themselves organized. I'll just make sure the chat too is nothing's coming in on that side. I'm going to just start us off, Stella. Do you think that, as educators, do we have to approach this, obviously we have to approach it in a different way. Do we have to, are there barriers to the time that might be needed to stop, discuss, get those viewpoints from the patient, the learner? Do you think that there will be challenges that we face as educators in this sort of changing delivery?
That's a great question, Jane. Thank you. I think, would time help? Yes. I think that even more than time, the elements that enable continual perspective shifting and continual growth and striving for everyday change and larger systems change, it's actually less time and more space. And when I say space, I don't just mean physical space, though that is a part of it. I mean the philosophical space. So it's more of that shift in orientation. And sometimes, so it might be a bit of reading or a session, a workshop that can then lead to continued change. And you might need sort of continual boosts on those types of reading and conversations and sessions. But it then becomes a part of your way of being and seeing. So those types of questions, critical questions like, what might the other perspectives be here? Who does this help and who does it harm? What am I not seeing? How else could I see? How else could this be done? Those aren't things you have to necessarily stop, think about, write down, talk about. These are questions that become a part of how you see and how you act. And I think that looking at Jennifer's question, yes, I do think that if we embedded these practices early, that change could become just sort of the way that people are. And I will say that many of our learners are already kind of seeing and questioning in this way. And we as educators and as the system that those learners are coming into kind of need to be open to that rather than sort of becoming the system that suppresses those forms of questioning. So yes, I think time can help. I don't think it's the key ingredient. I think it's more of that shift in a way of being and a way of seeing, which doesn't always add time.
Thank you. Let's see if there are any more here. So, Maria has shared something in the Q&A. She says, "Thank you, Stella. I'm breathing and letting your powerful words and stories sink in. It seems to me that humility is an important part of critically reflective orientation. Can you talk a bit about this in contrast to critical reflection, sometimes sounding, pairing critical? I wonder what tone does to invite conversation, change, emancipation."
Thank you, Maria. This is something that I think you know I've been grappling with. I do think the word critical can have a sort of negative or maybe even scary connotation to it at times. And it can be confusing because people might think of it as critical thinking, which it's not, or criticism, which it's not. I think that humility may be a part of it. For me, the fundamental piece of the critical in front of reflection is the attention to power, oppression, systems. And I think you have to have humility to acknowledge all of that and how we are all. The reason I shared so many examples of myself kind of messing up and not seeing is we are all a part of it. We are all complicit. We're all a part of the system. So some of that needs, I believe, some of that criticality. And I sometimes worry that approaches that focus on humility and compassion without bringing in the criticality in terms of the body of theory behind criticality may not let us see some of the harsh facts, like the study that I cited about restraint. I think we might not even ask those questions from a place of humility. It's the attention to power, hierarchy, oppression, harm that helps us to see the things that happen for some, but not to us, and maybe not to our own little circles. But it's something I'm grappling with. I don't know. That's just me sort of musing on the topic.
Stella, there is also a comment Jen added to her comment about how technology could play a role.
Yeah, I think there's folks in this room who would know a lot more about that than I would. I definitely hear people say that technology can get in the way of dialogue and relationship. And yet I would say in learning contexts, I have not experienced a difference. And in a study that Victoria Boyd conducted in follow-up to the one I shared, so the one I shared with interprofessional groups of 5 happened in person, and the one Victoria shared was interprofessional groups of 4 online. Her study had even more powerful, impactful results than that first study. And it was all online. And then in terms of technology helping, I've definitely seen some potential there where we can build technologies in ways that either enable or disable. Ruha Benjamin writes a lot about the ways that technology in healthcare can enable more equity or disable equity. So I think that that's her work is worth a look. I don't think that's a subject I'm particularly knowledgeable about.
That's fine. Thank you. We have another question from Nancy. She says, "Thanks, Stella. I really appreciate your approach. Relationships are the root of this kind of learning, with clients, patients, with each other, and with our students. How do we encourage people and ourselves to move toward discomfort in interactions where we are seeing power imbalances?" Great question.
Great question. And I wish we could like unveil all the, show all the people and have a conversation about this. And I'm sure that's many of us will afterwards. So Bell Hooks writes a lot about this. And Megan Bowler writes a lot about this in terms of leaning into discomfort, not into harm or complete lack of safety, but the necessity of discomfort. Megan Bowler writes about a pedagogy of discomfort, where I think almost no matter which paradigm or tradition of education you appreciate, there's something in it. Arno Kumagai has this slide where he draws all the parallel. There's something in it that's about discomfort. So you hear about disorienting dilemmas from Mesereau. You hear about the zone of proximal development from the more sort of education sciences. And you hear about discomfort from the critical pedagogues. And what it all shares in common is that we need to sort of move ourselves beyond just the status quo, the norm, the familiar, in order to really grow. And I think with the power thing, it's such a challenge right now in society because it can quickly lead to accidental competition or a default mechanism of, well, I also have struggled. I also come from this or that background. I also have had a hard time. I have overcome these things. And it's really not about that. It's about everyone needing to rise in order for all of us to change and grow. And there are many of the authors I've cited are more articulate about that than I. And I see from Susanna, authors who talk, yeah, I can type them if that helps. And also happy to share my slides, which have some of these names. So Megan Bowler.
I think we can assist with that, Stella.
Great.
As well for people who would like to, have a little bit more of that, your resources as well. But thank you very much. Just sort of monitoring these. Oh, okay. You're adding a couple more. That's terrific. I'm just trying to be mindful of the time. Jen, what's our timing here?
We are good until probably about 10 to 10. So I'm going to give
10
so
to?
people can have
Okay.
a bit of a break and our moderators can go to their stations for 10 o'clock.
Okay.
I think this was such a powerful discussion, and that idea between empowerment and emancipation really I was sort of thinking about that, because we do so many workarounds, and is that really like, how does that drive to change? If you're constantly working around a system, you're not really changing the system for the better. You're just working around something that doesn't work. Does that make sense? But you have to do it. So like the question is, how do you drive that change when you know the system's broken and you're trying to work within the system, but you need to change the system that you're working with? And I think that was the question my head sort of went to.
Yeah, and thanks for bringing that up, because I didn't want to make, often when you're trying to make things simple and you create false dichotomies. And I don't think it's an either or. I don't think it's like workarounds are bad, they perpetuate the status quo. I think it's that workarounds alone kind of work within the existing system. And so we also need the other. We also need attention to try to change the system. And I think workarounds alone can be powerful because they enable, if you're being critically reflexive, so you notice a need for change for the person before you, you get that person before you, what is needed within the imperfect system. That gives you a sense of agency, a sense of control. And in a workforce that is tired and potentially burnt out after 3 really long, hard years and with workforce shortages continuing, I think that that's so important and powerful to acknowledge that everyday workarounds, everyday moments of compassion, small moments, everyday shifts in our language to just try. Sometimes I know it feels like, oh my gosh, I can't keep up with all the changes in language. But every time you do keep up, every time you use words that are potentially more inviting, more inclusive, less hurtful, that can be a part of the overall change. While also some of us who are in, like I'm in a very privileged position, not as bogged down in the system, I can maybe work on some of the broader change. And we work in partnership in that way.
And thank you, Stella. I think you kind of touched on what Juanita's asking here. She said, what is the one thing we all as individuals could do differently tomorrow to start the change? I think you've already started to touch on it, just that little day-to-day, that change in language, that change in tone goes a long way. Would you like to add anything else?
It makes me think of a book I read as part of the Collaborative Change Leadership Program, which it doesn't come from the things we've been talking about today around critical reflection. It's called Change Your Questions, Change Your Life. And I think that phrase, that title applies here, change your questions. And that can help change our perspectives and our practices and our views and our language.
It's amazing. Okay. Just check all of our boards here. Okay, I think it is all quiet on the Q&As. I think we'll just take this time to thank you, Stella, for such an interesting conversation. It was, I think we have all learned, experienced something from your talk this morning. And I think we've all have takeaways that will change our own practice. These little bits and pieces all will make a difference. So I do want to thank you so much for all that you shared, your personal stories. It's very meaningful.